and you'll let everybody in.
Well, we'll just give it a few minutes for everyone to connect their audio and things like that before we start with introductions in this session. Okay, wonderful. I see that most folks have their audio connected, so we'll just kick off and start. My name is Vanessa. I'm with the Skull Foundation, and it's my privilege to introduce this session today. Health Leads and Partners in Health have been, Last Mile Health have been part of the Skull portfolio for many years, and we've been supporting the collective effort around enabling community health workers to strengthen health systems globally. And so I'm so thrilled to have this amazing panel of speakers to share about how community health workers and community-based workforce strategies can help in the front lines of this COVID-19 pandemic. So I'll let the speakers introduce themselves before we get right started.
So we could do a quick round of introductions. I'm Alexandra Quinn. I'm the CEO of Health Leads. Let's go. Rishi, you want to go next?
Yeah, hi, Rishi Manchanda, CEO of Health Begins. Thanks.
Denise.
Hi, Denise Smith, the Executive Director of the National Association of Community Health Workers.
Claire, you want to jump in?
Sure. Hi, I'm Claire Qureshi. I'm a Senior Director with the Community Health Acceleration Partnership, which is hosted by the Office of the WHO Ambassador for Strategy.
Raj.
Hi, everyone. Raj Punjabi here. I'm with Last Mile Health and the Community Health Academy and Harvard Medical School. Good to be here.
And Emily.
Hi, everyone. I'm Emily Rowe. I'm with Partners in Health and Harvard Medical School. And currently, I'm the Director of Design and Implementation for the Massachusetts project with Partners in Health.
Thanks. So we're really excited to put this session together. A few of you may have attended a session we did last Thursday and had the opportunity, thanks to Vanessa and the Skull Foundation and the Catalyst 2030 work, to very quickly put together another session. If right now on the screen is getting comfortable with Zoom, I think we all may be overly comfortable with Zoom now. I don't know, I can speak for myself, but please, one thing we'd love to do is also just put who you are and where you're from in the chat so we can just get to better know you. We're hoping at the end we'll have time for questions, but at the least feel free to use chat. So here's what we love: first name, last name, organization, and one thing you're hoping we'll keep in mind during the session. So we are a group of allies. We're still kind of closely came together over the past few weeks. As you heard on the phone, who we have today, it's a group that's been focused on community health workers and community investment for many years. And we've been able to come together. Probably one of the only silver linings of this moment in time is getting to be in groups with folks like all of you around the table and then the panel too. Here's what we're hoping you get from the session. One, just understand the context for US contact tracing initiatives. And as we've been talking about enhanced contact tracing, talk about the central role that community health workers are going to play, not only for COVID response, but also recovery for the years to come. And then based on learning from a global context, which a few of the panelists have, what are some concrete strategies for the US? And then what are 3 newly emerging recommendations? So before I get started, I want to acknowledge a few things. One, that we can all be here around this table today because of all the people that aren't around the table. That's folks on the front line, doctors, nurses, grocery store workers, janitors, those delivering our mail. Some of our panelists play a role. Both, you missed a conversation of Raj and Emily talking about the direct service they're going to be doing even this week. And it's a tremendous privilege at this moment in time when there is such tragedy to be able to also talk about systems change. And I was reminded about that as a person, because I also want to acknowledge that not only do each of you bring your perspective and the panelists bring the perspective, but a lot of us and a lot of you are probably bringing a tremendous sense of loss and sickness and everything that's coming with this moment in time that, you know, is so hard about the moment in time. And I was on the phone, well, first with a good friend of mine who, as of Friday, it's one of my best friends, her dad was admitted Friday night for COVID. And on Tuesday night at around at 11:11, her father passed away. And I woke up on Wednesday morning to a text from her. And she and I immediately got on the phone and I was just there to listen. And she hadn't expected this. She is probably one of the strongest people I know. And I just sat and listened to, what do you do when you suddenly lose a parent? What do you do when her father was a huge member of his community? He was a psychologist, a Kaiser doc. He sang in his choir. He was big in his church. And when a community can't actually celebrate a person. And, you know, I didn't have any answers, but I could at least listen. And what was amazing to me was we had to get off the phone. It was around 7:45 my time because she's a second grade teacher. And she said, I need to go to do my morning meeting. And I asked her, what do you mean, like you're going to do your morning meeting? And she goes, well, my second graders need me. And then she told me about how she had actually sent a note to all of her second grade parents as soon as her father passed away to tell them how she wanted to be there for them, how she wanted them to talk to their children about it, and how she wanted them to explain that she wouldn't be able to be there for the rest of the day. And so to me, those are the other heroes, our teachers, others who are experiencing loss in their community, particularly communities of color, where not only are you losing people at a rate that is just simply unacceptable, you can't even celebrate their life, which I hope we get to do later on. So I wanted to bring that because I know probably even more than me, each one of you brings your own piece of that, and want to acknowledge that it is a tremendous privilege to be in this room. And one of the silver linings for me in this work is sessions like this, that for probably the first time in my career, I am seeing a level of innovation and collaboration that is only born out of tragedy. And so for me, I'm going to hold both of those, just the innovation that you'll see around the table and the collaboration, and then that of the backdrop, which is not in this room other than living in each one of us. So I want to talk a little bit about this concept we've been talking about at Health Leads, which is meant as table setting for the rest of the conversation. You know, the moment in time we're in and the deep health inequities that feel like they're on warp speed right now have long been in play, hundreds of years have been in play in communities across the country. And as we've been talking about the flattening the COVID curve, at Health Leads and others, we've been talking about, well, there's a second curve, there's a second crisis, which is this surge in demand for essential resources. So food, housing, mental health services, the immediate and the long-term needs of COVID. And what this curve tries to demonstrate, and this is thanks to Dr. Sheena Nam from Health Leads, who put together this kind of predictive, this light predictive analytics around what is this demand surge that we're also going to have to use multiple interventions to combat. And the bottom part of the curve, the reddish pink, is our social service capacity as in the US as a country. And we could do this in other countries too, look at it, but right now this is just going to focus on the US. And what this looks at is, even before COVID, we were not able to meet the demands of our citizens, of our residents and community members. So we weren't able to meet it around housing, food, mental health services. We weren't able to meet it around ensuring that there's basic health equity. And then when we started to shelter in place, that's that first kind of peak. What we saw with things like free and reduced lunch suddenly not being available to kids across the US, 30 million kids depend on free and reduced lunch, is that there was an even bigger gap between what are the social resources or the essential resources that people need and how are they actually accessing them. The table setting I'd like to do is, we believe this is not a problem of just COVID, but this is a demand surge we're going to see for many, many years to come. Because even after we stop sheltering in place, due to the job loss, which the St. Louis Fed predicted was going to be about 32% in the United States, we're going to see increased unsheltered, we're going to see increased food insecurity, increased and spiked mental health and other abuse, neglect. And so for us, the call to action is, and what this call is centered on, is how do we as a collective start to close that gap? How do we as a collective have multiple interventions that enable us to address the social needs of all of our communities? And each one of my colleagues on the phone is steeped and well-versed in the work and is really coming to offer, how do we think about coming together and really serving our communities? So I will pass that off to Rishi.
Alex, thank you. Can you guys hear me okay? Yep. Thank you first for providing the opportunity. It's an honor to join you again and everybody who's on the line, seeing a lot of familiar faces and friends. We pulled together some of the same friends you're seeing on your Brady Bunch view right now on Zoom. And so if you're getting a little bit of a parallax thing happening, you're seeing on Zoom, you're seeing a picture of a Zoom call. And you'll see, perhaps some of you will see your own faces and familiar faces here. Last Thursday on the 23rd, which feels like weeks ago already, we had the privilege of co-hosting a call to speak about it in the US context, what a community-based workforce looks like. I think what was clear last week in conversations leading up to the call and conversations since in one-on-ones and bilateral conversations and these multilateral conversations that are emerging, at least among this emerging group of allies. And I'm sure this is true for many of you. I think we know some basic truths. One is that there are some who are lamenting the loss of normal and lamenting that we will not go back to whatever the quote unquote normal is. And there are those who are also celebrating that and hoping that we don't go back to what normal was as well, given the gross inequities that define too much of society, including in the US. And so the opportunity that we started to talk about in the backdrop, I think, of our conversation last week, and I hope informs this call as well, is the opportunity here to create a more inclusive, more just, more equitable normal. And much like other major political, geopolitical events in the last century, whether it's the formation of the Universal Declaration of Human Rights post-World War II, or the rise of the Global South and independence movements as empire started to fall last century. I mean, the only things that we can look to are global events, and we're experiencing a global event right now. The question is, what kind of new normal do we establish? When it comes to the US context and the concrete kind of conversations we're having today, and many of the conversations you're part of, I'm hoping that we can think through what a community-based workforce looks like and what the concrete objectives we have for this call. So especially as we think about creating a new, more just normal, more equitable normal. As we last week focused on community health workers at the center of that, and I think today we're going to try to honor that as best as we can here. I'm a physician, CEO of Health Begins. I'm not a community health worker, but I'm proud to have learned at their feet for the past 20 plus years of my career. And so I'm particularly pleased that Denise, you're here with us, and many faces on the line here today. Julie, Carl, many others I see who are leaders, who are community health workers themselves are on the line. So I'm hoping we can give you space. So with that, I think the next slide is really about this current context. How do we actually center historically marginalized communities in this moment? How do we actually put community health workers and promotoras at the center of that to be able to create a more just, more equitable space? In the context of emerging calls for contact tracing, briefly, we're seeing many people calling in the US at least for what we know we need in addition to testing. And in addition to a lot of other social protections right now, we know we need contact tracing if we're going to emulate best practices globally for how to decrease community transmission of COVID. The question is, as we're looking at congressional proposals, like the ones you see at the top line here from bills in Congress that are now being deliberated, including a more recent bill in the middle called the Health Force Bill, and you look at other private sector proposals, as you can see on the bottom line there, the question is, how can we make sure that while the understandable advocacy and initiatives mount to create a surge in contact tracing, rightly so, that we leverage these opportunities to center community health workers, center marginalized communities, center through an equity lens, so that we can create that more just new normal. With that, I think we'll speak through this conversation about different ways this is taking shape in the U.S. But to give us a global context and to speak about what this looks like in the U.S., I'm proud to hand the baton over to Claire Qureshi, who I've gotten to know in the past 10 days.
Yeah.
and admire tremendously. Yeah, admire tremendously. Thanks, Claire.
Thank you, Rishi, and that was very helpful just framing for this moment and just the political landscape. I think, while most folks on this call are keen to get into the nuts and bolts of how does contact tracing fit into the broader CHW scale-up landscape and discussion, I wanted to just set the stage a little bit for how community health workers, the story around community health workers has unfolded globally. And I will invite Raj Punjabi as well to please contribute, because he's been a key player in all of this with our team. But many of us, and I'm sure many folks on this line as well, have been involved for the past, personally, last 8 years, but it's been decades behind that, of really thinking about how do we scale up community health workers in sub-Saharan Africa and in Asia as part of the necessary task shifting because of the low human resources for health, but also because community health workers are a tremendous asset in hard to reach places. So about the last 7 years, as part of the march toward the Millennium Development Goals and then the Sustainable Development Goals, we've been looking at a number of areas to support the global scale up of community health workers and community health as a system. 3 of these are financing. So we did an ROI case, many of us, including Raj in 2015, that translated into the Financing Alliance for Health, which is a team that actually supports ministries of health to develop a comprehensive financing plan, patching together bilateral and multilateral to sustainably finance their community health strategy. It's now run by amazing Kenyan women, I think 5 Kenyan women, it's incredible. Second is management capacity, realizing that ministries really do need surge capacity to build strong community health systems, and ministries and their partners. So the Aspen Management Partnership for Health works with ministries on leadership and management capacity around community health. And the third is on standards and norms around community health. And leading NGOs, including Last Mile, including many others, came together and formed the Community Health Impact Coalition, which intends to make professionalized CHW the norm. And this has really, been helpful also in getting the WHO to launch guidelines on CHWs in 2018 to give some solidity to the overall effort. Just to say though, and I mentioned in the lead of this slide, the Ebola epidemic really galvanized attention around community health workers. And Alex in her opening talked about this being an incredible moment of innovation and collaboration, but I'd also add to that opportunity. And I think one, very small silver lining of all of this, of COVID, is the opportunity to take community health workers forward. Before I go to the next slide, Raj, do you want to speak any more about just your team's involvement in some of these pieces and how Ebola has become a framing moment and a galvanizing moment for the community health scale up?
Yeah, thank you, Claire, and thanks all for joining. I can speak to that. My first orientation to community health workers was being taught by them 20 some years ago in the tundra in Alaska, where the Alaskan Native Health Service, some of you may have worked with, has hired, trained, and equipped several hundred Alaska Native people to actually be community health aides and staffing community health clinics. And today they address medical and social needs. But when they started in the 1950s, it was in response to a tuberculosis epidemic. And there was a shortage of medical providers, and there was a crisis, a tragedy that born collaboration in creative ways, as Alex was saying. And over 50 years, they've established one of the most equitable rural health programs in the country. They have even taught the workers there know how to do microdentistry, diabetes care, and they're addressing social needs. A few years ago in Liberia, which is where I've had the privilege of either growing up or working for nearly all my life. We faced another epidemic, the Ebola epidemic. And much like the Alaskan community health workers, Liberian community health workers stood up when that epidemic threatened to bring humanity to its knees. I remember just how afraid everybody was, the doctors, the nurses. And I'll admit I'm going to be volunteering in a COVID clinic on Sunday. And it's the first time I'm having a chance to do that. I'm afraid. And it was what got them through that. When humanity was being brought to its needs is this commitment that I think many of us share, but community health workers absolutely do, is this commitment to serve your neighbors. And they teamed up with doctors and nurses to do contact tracing, to do case finding, to bring patients into care, to help break the chain of transmission. But after that, much like the case in Alaska, the people of Liberia made a commitment to never have that happen again. And so the government decided to hire, train, and equip a community health worker to be within reach of every community from those communities, people without a high school degree in many cases. And they're addressing the health and social needs. And today, because that workforce is in place, Liberia is not only better equipped to deal with the everyday epidemics of premature death and lack of essential social services, but also these workers are now being trained and equipped to deal with COVID, and they're able to do it much faster than the Liberian government would have before. So, we're teaching an online course, and I think some of you have joined from that. Several thousand Americans are involved, but there are examples like Liberia's, Ethiopia's, Bangladesh, Brazil. I mean, whether it's in the US or abroad, the simple thing we learn is that if a health system and a country invest in the people closest to the problem, we're much more likely to be able to deal with crisis, the everyday kind and the emergency kind. And so I think, one of the exciting things I find in this moment is the opportunity here in our country to be able to, in the United States, to be able to join forces with these type of initiatives like the Health Force Bill to hopefully employ the many hundreds of thousands of people, millions that have been unemployed, and to bring them into the health workforce. But importantly also, and I imagine our friend Denise will speak to this, to ensure that the existing community health workers are recognized as for their work. We know for too long, abroad and here, that often the poorest people, the people who are the most marginalized, people from these communities, are not compensated, they're not recognized. We know around the world that the poorest women in the world, many of whom are working on the front lines of this crisis right now, as community health workers, also as nurses and midwives, are going unpaid, underpaid at the tune of over $1 trillion every single year, subsidizing healthcare essentially with their unpaid work. So, when we clap, we've got to remember that pay gap and help to close that too, those historical inequities that have existed. So I'm just thrilled. Last Mile Health, in whatever small way we can support efforts, we'd like to, and just grateful for the community that's coming. I think this is a moment that will be unlike any other.
Thank you, Raj, and thank you for giving such the the personal take on it and how you've been a part of it, and everything from Alaska to Liberia and back. And the passion from that and the real learning and the point you made around recognizing this health workforce, I think, is critical. Unfortunately, those arguments should be enough, but they're not always enough to convince policymakers who might have, the health interest, as we've seen globally, should be enough to compel action, but it's not always. And sometimes you have to speak to the finance minister and have to speak to the prime minister who may have more economic concerns. So I want to just take it forward to the next slide and talk about the case we've all made globally and challenge the group here. We're already a long way towards this, but in addition to the incredible stories we're telling about CHWs, we have to also do the analytical work behind it to make the case to CMS, to governors, to state legislators to fund this critical resource, and now to policymakers in Washington who are thankfully wanting to do things like fund a health force. But collectively, building on those items that I mentioned in the prior slide, we made the case about community health workers, lives saved, the economic return on investment, and the jobs that will come from this. And we found something like $7 to $10 in economic gain per dollar spent on CHWs. It's cost effective, that we're employing, and to Raj's point, particularly vulnerable women, and this incredibly powerful cohort to employ and to respect and to lift up. And then the proven results, we have a long track record globally now, 75% reduction in child and maternal mortality in Ethiopia, for example. And I know a lot of programs here are beginning to really build this evidence base as well. So just to provide what we've been trying to do globally and how it's been powerful. But next slide, just quickly, a lot of this work has then translated into a roadmap for community health that's brought in all the ministries of health in the countries in sub-Saharan Africa, as well as a catalytic fund to encourage investment into community health beyond that. And it's been a way to rally ministries and also donors around the community health priorities and make sure that we're really helping in an organized way lift up those key priorities identified by communities and by governments, and making sure their voices are heard. And then just the last slide, I think, let's see. I'd challenge us in the US to build a strategy that takes some of these lessons to look at the financing environment as we are. What can CMS do? What can we do through bills like the Health Force one that actually makes CHWs, federal employees potentially? What can we do about management capacity and networks, especially right now when there's such critical asks being made of departments of health? What can we do on hiring and training to really bring in best practice? And as we're surging these contact tracer programs, can we really think about how we're doing that in a high quality way and providing the training that's so critical? And how can we think about credentialing and accreditation and certification? It's very complicated. People have lots of different perspectives on this, but we should be thoughtful, and it should in some ways be state driven and program driven about the right amount of credentialing in each program. So last slide I want to leave you on is just to think about on the financing side. This is totally illustrative, but if we think about where we are today and very minimal reimbursement of CHWs, that bottom bar in the chart, through Medicaid, maybe some funding coming through the emergency, the CARES program. Again, that's aspirational, not real. And again, aspirational philanthropic funding. But if this is the picture potentially of 2020, can we get to a steady state in 2022 where there's actually long-term sustainable funding coming through vehicles like CMS that would provide the platform of financing that's critical over time? So again, these numbers are made up. We need better data, but just that mindset of we're in a crisis now, let's take the money we can from it, but over time we need long-term sustainable financing to really support CHWs. And to any philanthropic organizations or funders on this call, I would really say that what we've seen globally and we see in the US, your philanthropy is very powerful for getting things started, supporting collaboration, providing help to states to bring in the technical assistance they need right now. And I would encourage the funding community to take that active role as you can. So let me turn it over.
Thank you, Claire. And I'm going to turn it over to Emily.
All right, thank you. Hi, everyone. Again, I'm Emily Rowe. I'm from Partners in Health, and I'm going to talk a little bit about the contact tracing program in Massachusetts. So I thought I'd start with a little bit about the program and pivot to the workforce. So this is my one slide on what we're calling the four-legged stool of efforts to stop community transmission of COVID-19. I'm told the metaphor is supposed to be a three-legged stool, but given the audience, I think you'll all allow me the fourth leg when I get to it. I think you'll like it. But the point of this really is, I think this is kind of like the health system strengthening slide for COVID-19 on really focusing on the only way we're going to get the pandemic to reduce and get that magic R number under 1 is to stop community transmission. And the key point here is that contact tracing really could almost be in the center of the circle. It's kind of the nexus or pivot point for stopping community transmission. And that's because it's related to all of these 4 steps that I'll talk about in really big ways. And it's also the piece that is touching both on cases, people diagnosed with COVID-19 as well as contacts. So it's related to testing because it's a linkage to care thing. The minute somebody tests positive, or if they test negative, people need instructions on what to do next. And so the next step is the contact tracing, which I'll talk about the workforce we have for that. But really this is about reaching out in a really comprehensive way to people in their homes across the state of Massachusetts, diagnosed with COVID-19 or who may have been exposed, and helping accompany them through what the next steps will be, helping them get the information that they need, get their questions answered, and really supporting them through what follows, which is isolation and quarantine, which is why there on the lower left, we have it really tied to what we're calling protect, and that's to protect the person and the community. And we're using that language instead of putting the word isolate or quarantine there, because really the way the community needs to come together to make contact tracing work is to support people through isolation and quarantine. So it's kind of it's a hard thing, right? Where we're trying to isolate away from each other in order to come together. And I think making sure that people can safely do that, can effectively do that is really what we need to stop community transmission. And so I think if the social contract here is expecting people to be able to safely stay apart from family and loved ones, at a distance to reduce transmission, we have to make sure that we can support them to do that. And then the fourth leg of the stool here is what we're calling support. And this is really the social assistance piece of this, and the making sure that we identify vulnerable cases, vulnerable contacts, vulnerable communities, and meet their needs and walk with them through what we need to do to address COVID-19. And we get a lot of questions. I have received personally 1 million emails about tech since this started. So that's an exaggeration, but there is definitely an incredibly key role for tech to play. It can make things easier, more efficient, help with data systems. But we know that this is really a system built on a backbone of humans. And this piece is the human part of reaching out to people in their homes. We're here, we're with you, how can we help? And so, I've heard a lot of people call the project we're doing a call center, because we're doing this all virtually and we are calling people. So in some ways there is sort of a thing that's a call center that's part of this. But it's really so much more than that. And I think that's probably really obvious to this audience. So I started this place where our staff can submit kind of notes from the field on their experience. And, the stories coming in are everything ranging from how grateful people are to hear from us and just be kind of like helped along with information and making a plan, as well as people needing to find a PCP and needing linkage to testing when they're a contact and they develop symptoms, to I have to go to work because I have to pay my rent, or I might get evicted, or overcrowded housing. I mean, I could go on, right? So this idea of linking kind of social assistance to contact tracing is incredibly important. And so our workforce is over 900 people right now that we've hired in under a 3-week span, all from Massachusetts, speaking more than 20 languages, and all from all walks of life, but very dedicated to the community. And many of them are doing the contact tracing. So the phone calls where they call cases for case investigation, or they call contacts to let them know they've been exposed and help those people learn about isolation and quarantine. But we also have a cadre of resource coordinators who are functioning to connect them with community resources and community organizations, and do that leg of the stool around support. We've just been joined by many staff from community health centers, and their community health workers are slotting into that resource coordinator spot. So I think thinking about the CHW movement right now is, I just worked for 5 years in Malawi on community health worker programs, and we just did kind of 6 months to a year of hiring, training, and getting things going in less than 3 weeks. And so I think the challenge here with COVID-19 is a couple. And one is just, how do we rapidly hire, train, supervise, and support at scale a cadre of workers who are linked up to the CHW movement, who are involving community health workers, who are joining the community health worker force when that's appropriate? And how do we hold that urgency and scale in our hands, as well as all of the principles that we hold, dear about community health work, connection to community values, empathy, the support we provide to them, communication skills, and sort of professionalizing that. And I think all of that's really important. You know, some of these contact tracers will be community health workers and some won't, but I think those principles are incredibly important, and how to do that very rapidly and to scale is a challenge, but really an opportunity. So I see a lot of hope in this, and how to kind of learn from the community health worker community and involve and have these kind of things talk to each other and find kind of hope and optimism in such a time of uncertainty and fear and sorrow. So I'll stop there. That's what I had for today. And for the next slide, for the next person. Thank you.
Thank you, Emily. All right, Denise, you're up next.
Well, good afternoon, everyone. Yes, thanks, Alexandra. Alexandra, I just appreciate the way that you set this whole thing up today. And I just want to elevate a couple of things that are so critical as we consider solutions and partnerships, so where we are and where we're headed. Before the pandemic, there were 100 million people in the United States who were living at or below 200% of the federal poverty level. Before the pandemic, there were at least 28 million uninsured, non-elderly individuals. Before the pandemic, there were 530 indigenous nations, those many more that are not recognized by the government, as well as African American and Hispanic American communities for whom housing and clean water and limited access to the internet, lack of healthcare coverage, disproportionate preventable chronic disease were already coming together in this perfect storm over hundreds of years to severely deplete community resources and ravage community health. Before the pandemic, there was already rising stigma and violence against Asian presenting communities, as folks spoke about this being a Chinese virus. And there were decades of historic stigma and bias experienced by our LGBTQ brothers and sisters, for whom emotional trauma might impact their willingness and their trust to access the healthcare system, and may result in delayed accessing of healthcare. So it remains to be seen if a lot of the solutions that have been lifted up, and Rishi referenced some of those earlier, it remains to be seen if those will truly have an equity lens as we go forward. But many of them, as the previous slide points out, are calling out community health workers as part of the solution. And so, as the founding executive director of the National Association of Community Health Workers, it is a high honor and quite humbling to lift up this highly diverse workforce, working across sector in rural and urban communities, through every ethnicity and language, paid and volunteer, and with origins of commitment and compassion and engendering of trust and respect in community that is irrespective of where you may find us working. You may find us working at federally qualified health centers or hospitals, but more often you will find us working in the community or as volunteers, conducting outreach. And so we have a particularly important role to play now to enhance public health capacity. And as Alexandra said, for the now and also for the rebuild and the recovery in the context of all that was broken before the pandemic. CHWs have been doing this for decades. We're the doulas. We are the navigators. We are the promotores de salud. We're the violence prevention outreach workers. We're the HIV intervention specialists. We're the home visitors. How we do it and the unique qualities that I would like to elevate as we begin to take a look at this slide in terms of why community health workers are needed now to strengthen public health emergency response is because we lead with strong values of dignity and respect for all people. We build trusting and sustainable relationships, and we often share lived experience with the communities that we're serving. This is why we are a critical workforce to address all of these historic inequities that I listed out and have been shared, but also to address the tens of millions of people who have lost employment over the last 6 weeks, who have never had to access some of the critical services that are needed now. And so I am introducing and offering 3 really high-level strategies that public and private institutions can consider when they are looking to understand the unique approach or the roles of CHWs and the way in which I think they should partner with CHWs. And I want to be clear that there's a lot of work to be done. There are hundreds of thousands of people that probably should be hired when we talk about contact tracing, when we talk about testing, and when we talk about the recovery and the rebuild of people's mental health and their access to those needs that will help them achieve their well-being. But CHWs have a key role to play, and I was heartened and encouraged by this first point here, that in March of 2020, the U.S. Department of Homeland Security classified community health workers as an essential critical infrastructure workforce and gave guidance to the states, many of whom have not yet adopted, and so we're encouraging states to consider this language, to pay CHWs as part of the response to COVID-19 because we work to protect our communities. The services that we provide are protective, they are reparative in terms of their public health approach, in terms of their focus on the social drivers of well-being. We help to ensure continuity of services for those who cannot access telehealth, who live in a digital divide, for those who live in a transportation divide and cannot drive to a testing site or don't have a telephone, and so they cannot easily receive their test results once given. So classifying CHWs as essential critical infrastructure workers for us is a start because it can acknowledge our roles and our skills. The second is real important, and it's been emphasized in other slides in a global context for sure, but I am encouraging public and private institutions to fund CHWs and CHW networks so that they can fully participate in this scaling up of capacity for contact tracing, testing, and care coordination services. I have heard often that the folks who will take on these roles will be volunteers, that they will do so out of the kindness of their heart. But I want to remind people that this workforce, as Raj and others have spoken about, have cultivated their skill and experience over decades. Right? It is their life that they apply to the work. That is the nourishment for their expertise. Yes, many are trained. Yes, many are certified. But we want CHWs and CHW networks to be acknowledged for the grassroots organizing that they have done over the many decades. It is why the National Association is here, because CHWs were organizing and networking. And we've seen that here in the United States most obviously when we consider HIV/AIDS. The last is to really recognize CHWs as leaders to drive improvements in health equity, social justice, and healthcare delivery. And I'm really excited about this because I like to emphasize that with all of our roles and skills and competencies that folks may be aware of, CHWs are not just effective for downstream service delivery. Yes, we have much expertise in cultural and linguistic diversity, in reaching our communities and developing relationships, et cetera, et cetera. But we are also individuals who have intelligent insight and capacity to lead innovation and change. And so this is an incredible time for us to consider what old systems or approaches were actually not working for our communities. And if we can receive information and allow CHWs and our network leaders to participate in this emergency response effort, in workforce development planning, in other opportunities to talk about long-term recovery and rebuild, we will have the voices of our communities present at the table. We will be able to center equity and social justice. We will remember that CHWs have been doing this for a long time, and when we invest in them, when we center them as leaders, they will meaningfully contribute to the transformation of many of our systems. So thank you, Alexandra, thank you to the school and to all of my peers here for the time.
Thank you, Denise. So now you can understand why I'm feeling hopeful after you've heard all of my colleagues speak. I'm going to pass it back to Rishi to do a quick wrap up and some emerging themes, and then we may have some time for Q&A. We are all going to make ourselves available to continue to build this movement. So we'll see how much time we have left at the end. So Rishi, can I pass it back to you?
Yeah, I think, and I'll thanks, Alex, and thanks, Denise and Raj, Claire, Emily. We have a few minutes left, and maybe I'll use this to both ask for an advancing of the slide and then opening of the mic, because there's a lot of emerging resources. You've heard several so far, and we'll make these slides available as the recording is as well afterwards. Resources from a variety of peers represented here today. These are resources that were shared at the end of the last week's national strategy call, and you can see there's a variety here at the next slide. Oh, Alex, and I'll just go through these really quickly. Sorry, I think this is what you're going to go through. So hopefully it's okay if I just kind of run through this really quick.
Yeah, go for it.
Okay, great. We've got the resources here on the next one. The next slide here, we've got some emerging strategies and really that unpack some of the ideas over here right now. And I want to call out several wonderful articles, that including from Health Leads, Raj and others, as well as action alerts, specifically from Shreya Kangovi and leaders at the Penn Center for Community Health Workers and ASTHO, as well as what Denise and the National Association have been putting forward as policy recommendations. So really highly encourage a lot of the kind of vigorous contributions and brainstorming of the ways we can move forward as we go from the storming phase into the forming. Let me open the mic up as we go to the next slide here, Alex. As we think about like the emerging recommendations here, and instead of having me kind of recap what we've talked about, let's actually just open the mic up and let people talk. So let's pause over here, and I'm wondering if I see a friendly face, a CHW as well. Julie, I'm going to have a preferential option in calling on CHWs, and maybe we can popcorn this. So Julie Smithwick, are you on the line? If you're able to be unmuted, or if you can unmute yourself. Julie, quick question. We can hear you, yeah. What does a new normal look like in terms of creating a more just world, especially with CHWs and promotores in the middle? And reflect on both what everybody has said, including Denise, but others. Just what's meaningful for you as you think about your experience as a CHW?
Supporting us in a sustainable way to do the work that only we know how to do. And when I say only we know how to do, I don't mean that CHWs are the only people that can, help navigate, but we are uniquely positioned and have unique skills and qualities to both address the everyday needs that people have and the things that they're struggling with, but also to be portals to voices in communities that are often left out of conversations. So, we need to be at the table helping to make these decisions. We also need to be supported in a sustainable way, not as volunteers, not as people who, yes, we do this out of the goodness of our heart every single day, but we also need to take care of our families and ourselves. And so I think that, what I'm looking forward to is an advocacy strategy where, as, a couple of people have mentioned, we can use this opportunity to show how essential that we are as CHWs, but not just stop there, build a sustainable strategy so that going forward, we can continue to be in that place and continue to make that difference.
Amen. I'm going to ask Sergio Matos. Sergio, are you in the line? I see your name. I don't see your face, but I'm hoping you can hear my voice and unmute yourself. It's been years since we've seen each other. You are very active in the community health worker space, especially in New York. Sergio, yeah, take the baton from Julie.
Yeah, hi, Rishi. It's wonderful to see you. I think what's occurring to me is the cyclical attention that's been given to CHWs. I'm old enough to have been a member of the Black Panther Party and the Young Lords. And so I've learned throughout my life that a lot of attention gets paid to CHWs when the country and the nation is in crisis. But then when those crises, when CHWs address the crises and the crisis is eliminated, we become unsustainable. And I think Claire spoke to this a little bit around long-term sustainability. The other, and we need to be aware of that. The other big issue that's occurring to me is that I view community as larger than the residential geographical space where I live. And so I'm particularly concerned, I'm certainly concerned about my fellow residents, but I'm particularly concerned about the community of health providers and health workers. And I think that they too are in crisis. Here in New York, we recently lost the medical director of an emergency department at Presbyterian Hospital, who had been in that position for 15 years and killed herself last week after having been infected and recovered and gone back to work. And I think that that's a crisis that CHWs, if CHWs were fully integrated into systems of health, in this country, then CHWs would be available to that community as well, not just our geographic community, but the full community of people that we interact with and live with daily. And I think health providers are in crisis right now, and nobody's paying attention to them. So it's just an expense. Community health workers are a piece of the fabric of society. That we're not a construct. We're not, and you know this, I'm preaching to the choir, but we need to recognize that and stabilize that and make it integral to our system of care. Thank you.
Amen. Sergio, thank you. Yeah, Alex, before I turn it back to you and to kind of close us out, I just want to make one reflection that Sergio and others have unlocked for me. That pre-COVID, one of the major arguments we were making, Health Begins and with some of the other allies in the space about why it's important to move upstream to address social needs, social determinants, and structural determinants of health, was at least at the individual level, for taking care of patients. When you expand the team and you involve community health workers and promotores and the traditional kind of models of care, and you create the systems and the tools to support everybody on that new broader team, the psychological health of the providers on the team members benefits that. And that one of the angles specifically that we were arguing is that some research indicates that physician burnout rates are directly linked to not working in a system or in a team that can take care of this broader kind of range of issues that, again, community health workers and promotores are uniquely positioned to address. And I wonder if there's I just want to surface that and just to echo what Sergio helped me unlock here, which is it's not just about elevating and putting CHWs at the center, but it's by doing so helping to unlock and maybe provide some therapeutic benefit to what everybody who's feeling individually overwhelmed right now, whether you're a doctor or a nurse, a social worker, or others, can feel capable of that kind of support that comes by bolstering the team. Alex, I'll turn it back to you. This has been a phenomenal conversation.
Thanks, Rishi. So we see this as not the beginning, not the end, but an important middle piece where we're brought together, right? After hundreds of years of inequities, COVID-19, how do we rethink about the new normal together? And so while we're the panelists today, I see this, and I think we see this as a broader movement. So we'd love for you to engage us individually as a group. We're going to continue the conversation, hopefully with you all, hopefully with the experience of you all. So we'll make the recording available. I am deeply thankful to my fellow panelists. We literally pulled this together in 48 hours, and each one of them are very busy humans, so thank you. And thank you to everybody who was able to join today for being able to put the rest of the world aside for an hour and join us. And I really hope this is the beginning of a movement. So we look forward to seeing you again soon. I don't know if any of my other panelists want to add anything.
Keep safe, keep serving.
Yeah, and keep us energized and for all the great questions. We'd love to do this again and have more voices and representation from other places as well.
All right. Thank you, everyone. Be well.
Everybody.